going to kick off this afternoon's session with another didactic talk. This is coming from Professor Sven Plein. He's a BHF professor of cardiovascular medicine at the University of Leeds. It's with whom I started my whole cardio-rheumatology program, and I'm massively indebted to. He's going to be talking about CMR in the management of patients with cardiac involvement from an IMID perspective. Thanks, Sven.
Great, thanks, Maya. I hope the microphone is high enough for me. So if you can't hear me, then tell me. Great. So when we image patients with cardiovascular involvement or suspected cardiovascular involvement in IMIDs, echo is always the first line test in almost every situation. We've already heard a little bit about PET, but most people won't end up having an echo. This talk is not about echocardiography, but maybe in future meetings we can explore the role of the different imaging modalities in a little bit more detail. You good there? Good. Then second line tests, there are plenty. Cardiac MR is one of those. As I said, we spoke a little bit about PET in particular already. Cardiac CT is really important in everything to do with the coronary arteries, whether it's, as we heard, coronary stenosis, whether it's fat or inflammation, perivascular inflammation, etc. And then cardiac MRI is the topic of this talk. So cardiac MRI in general is quite good at things that are relatively big. So MRI is good at looking at the myocardium and things that don't move very fast. So the valves are not the strength of MRI because MRI is relatively slow in its acquisition. And coronary artery imaging is possible with MRI, but it's much better with CT because, again, MRI is quite slow. So if you think you want to take a picture of something that's very thin and moves a lot, if you have a camera that takes like 2 minutes to take a picture, that's going to be quite blurred. So in general, we use MRI where the myocardium is affected or involved, the aorta is involved, the pericardium, so the structures are a little bit larger. The real beauty of MRI is, in addition to the fact it's of course non-invasive, it doesn't use radiation, it's therefore safe for the majority of patients, is extraordinarily versatile. And you can do so much with MRI. And I've been working in this field for 20-odd years, 25 years now. And still, every few years there's something new that we hadn't done before that evolves out of the same physical or the physics principles, but you can modify what you do with the MRI scanner and the pictures in so many different ways. It's really fascinating how you can do lots and lots of different things. So one of them, the sort of bread and butter thing, and that's what MR imaging 25 years ago or 30 years ago was just anatomical pictures. So still images of anatomy. And it's still really useful. Every MRI scan today will include an anatomical overview that you look through for extra cardiac findings. You look at the size of the aorta, you look at the general anatomical correlations. Used to take like 10 minutes to get one picture when MRI first started. Now it takes a fraction of a second, but it's still part of every scan. The mainstay then of everything we do is a bit like an echo. There's cine images. We use them to look at left ventricular function, right ventricular functions, and all sorts of other things, valve disease, etc. And the benefit here is that you get pictures like this in every patient. Leaving aside arrhythmias and poor breath holding, even for those, we now have those who are overcoming that, where you get outstanding pictures with great signal to noise ratio, blood myocardial contrast in every patient for the left ventricle, the right ventricle, atria. There's no blind spots like in echo. There's no breast tissue attenuation. So the images are always, so within reason, always good quality. Then we can do this thing called T2 imaging or T2 mapping. And in a few minutes, I'll walk you through the physics of MRI. I'm just telling you this already. So you're going to walk away from here with something you had not expected that you would know at the end. And that hopefully keeps you motivated after lunch and keeps you awake. There's this whole T2 weighted imaging, which for now I'll just say is good for edema. So it tells us whether there's a lot of water in tissue. And then we have flow imaging. This is actually not the flow image. I'm cheating a little. So flow imaging looks a little bit pixely, and it's not really what I'm showing here. Generally, we can look at flow in different ways. We do that for valve disease. We talked about the patient earlier with the case from Leeds with mitral regurgitation. Sometimes we use an MRI scan to assess the severity of mitral regurgitation because we can very accurately quantify stroke volumes, flow through the aorta, and we can therefore pretty accurately calculate regurgitant fractions, which sometimes in patients with eccentric deaths, it's quite easy for them to do. Then we can do focal fibrosis imaging, that's late galenic enhancement. And again, I'll talk you through that in a minute, which we do for myocardial infarction with focal fibrosis, and then T1 mapping or ECV mapping, which is for more diffuse fibrosis. And then finally, we have perfusion imaging, which has moved on from being a visual assessment of looking at different gray scales of that looks better than that, so to quantitative perfusion imaging, which is now becoming a clinical tool, supported by a recent SMR position paper on how to supply these images. And this is a patient who's got microvascular disease. Perfusion is low, and the red perfusion on the outside is higher. It's a typical picture in quite a lot of patients with IMIDs. So I was going to demystify the whole T1 and T2 thing. And this is how we're going to talk about MR physics for 5 minutes. This is a gyroscope. And if you've ever held a gyroscope in your hand, you know what it does. It spins around, it rotates around, and it has a force. And actually, what we have in our body is lots and lots of gyroscopes. And these are the protons, the hydrogen atoms, because every atom in the body that has an unpaired electron is a magnet. And it also means it has a precession, a spinning property. So we have billions of protons in our body, and that's what MRI uses most of the time. We look at the protons and we play with them. And we use the fact they're little magnets inside our bodies to interrogate the tissue inside the body. So keep that picture in mind. It's the gyroscope that spins around. And these are now the protons in a very simplified way. Everything I say here about MR physics is extremely simplified, but I think it carries the concept quite well. So as you're sitting there now, of course, the Earth's magnetic field is working on you, and that's why you've got that spinning of the protons. But it's not strong enough to affect the direction, the orientation of those mini magnets. So all the protons are randomly. They're just, like you're sitting in the room, everybody sits slightly differently. That's where your protons do right now. But here comes the trick. We now put a very strong magnetic field around you in the MRI scanner, and the protons, the little magnets, will align with or against the magnetic field. And that's the trick. And that's why we need these strong magnetic fields. We need like a Tesla, or 2 Tesla, which is like 10,000 times the Earth's magnetic field. When you do that, then you get this alignment of the magnets with the main direction, the B naught field, that we often also call the Z direction. You can see that some spin with and some spin against the magnetic field. That's a bit too hard to explain. But it's the difference between those spinning up and spinning down that gives us the signal in MRI when we take pictures. But that's not what I'm trying to talk to you about today. I was trying to explain T1 and T2. So here's a fortuitous thing. I told you that these protons are spinning, or we call it precessing, so they're rotating around their main axis. And fortuitously, they do that at a frequency that we can influence. It's in the RF range. And the speed with which they're rotating, the frequency depends on the field strength, but with the field strength, we need to make them all align as we want. Luckily, that's in the RF range. So the first part of the MRI scanner is the very strong magnetic field, which we need to do what? Align protons with the magnetic field, so they're not all chaotic and don't give us any signal. You can't really work with that. Everybody doing their own thing doesn't work. Second thing of the MRI scanner is the RF pulse. So we've got them all aligned. Now we have an RF pulse. What would that do? So if you have something, do you know any examples of a situation in daily life or in school where you use the fact that you can excite something at a particular frequency? You've done a little experiment as a kid. You ever used a tuning fork? Resonance. Give it a tuning fork in the guitar. So what happens? So you put the tuning fork next to the guitar, and if you have an A, and the A string is an A string on the guitar. Thank you. What will it do? It takes up the energy, and then it sends you an echo back because it will start to vibrate. That's exactly what we're doing in MRI. So instead of the tuning fork, we have that's just illustrating that. So instead of the tuning fork, we have an MRI scanner. The MRI scanner sends an RF pulse into the body to hit all the protons that we said before were all nicely aligned, but processing along the Z-axis. What happens then here is you need to look at the little orange arrow. I hope you can see it. So the energy that we put in tilts the little gyroscope from going this way to going that way. It's a higher energetic state. So the energy we put in tilts that precession from being like this. You've got your gyroscope, which wants to go like this, and then you force it to spin like around like that in the XY axis. Great. Then we switch the RF pulse off. So I should say initially that all the little protons will spin like soldiers walking in step. So all of them will go around in synchrony, all of them. And that's really important when we come to talk about T2. So bear that in mind. Now we switch the RF pulse off. Remember, the external strong magnetic field is still there, and that goes in this direction. So that will force all of those spinning protons to go back to where they were a minute ago, to all go back upwards. And that's shown in this cartoon, which only plays once. So play it again, hopefully. No, go up and down. So you see how the magnetization goes back to being in the Z direction. And that's T1. So it's a restoration of the Z direction of magnetization when you switch the RF pulse off. We pick that up with the MRI scanner. We need to do a few tricks to understand where that signal comes from. That's basically T1. And then T2 is, you see the little soldiers here all spinning initially in step, and then over time they dephase, and now they're all going at their own rate. And therefore, in the XY direction, we had some good magnetization when all the soldiers were doing the same, all the protons were doing the same thing, but now they're dephasing and they're going at different speeds. And then we lose that magnetization in the horizontal or the transverse plane, and that's T2. That wasn't so hard, right? So how do we use that for imaging? So the next fortuitous thing is that different tissues have different T1 and different T2 properties. That's all related to the fact how closely linked those protons are. You know, what's in between them. You can imagine you've got soldiers that hold on to each other. It's much easier to walk in sync. If they all, walk separately or they haven't got strong bonds, it's easier for them to desynchronize. And that's why different tissues have different T1 and different T2 properties. We can now generate pictures that reflect those two different properties. So we can make what's called a T1 weighted image or a T2 weighted image. The T1 weighted image is more interested in the difference in the restoration of the Z direction. The T2 is more interested in the dephasing, the T2 property. And then it's just lucky that fat, muscle, and fluid have very different T1 and T2 properties. So we can generate pictures like this. We can have a T1 weighted image where you can see the fat's really bright. And we can generate T2 weighted images where you can see here there's a bright bit here in the anteroceptum, and that's an edema-sensitive picture. So the observant of you may ask a question. They will say, well, hang on a second, T2 weighted imaging is sensitive to fluid. Which bit of the right-hand image is not bright that should be bright? What about this bit here? Shouldn't there be lots of water in there? Well, we use an additional trick, and right over there we have tricks to get rid of the signal in the blood, so we take that out. But you would have been right if you said, well, that should be bright because it's fluid. So well done for those who observed, but it wasn't many. So that's imaging, T2 and T1 weighted imaging, which is visual, it's qualitative. It doesn't give us a number. We can't really say today, it was this bright, tomorrow it was that bright. So we want numbers. So we can also measure the time it takes for each voxel to go back to that longitudinal or to lose that transverse. What was that? Lose that transverse magnetization. That's mapping. So that's basically the same thing as T1 and T2 weighted imaging. Just instead of doing it qualitatively, we actually generate some numbers by taking a number of measurement points along these relaxation curves, and then we can calculate the number. That's T2 and T1 mapping. The final bit to understand is the contrast agents. We use gadolinium-based contrast agents, and they do one thing very well. They shorten T1. So wherever they mix with blood, in the tissues that they get into, when we take the picture, when there's more of the contrast agent, the T1 will be shorter, which in MRI terms leads to a higher signal. because, short T1 means it goes back to that origin magnetization much quicker. And then we take a picture with the correct pulse sequence, we can see where all the contrast goes. And the cool thing about the contrast agents we have is that they cannot enter intact cells. They are completely extracellular. So in normal myocardium, they'll just be swimming around in the extracellular tissue, which is about 25% of the heart. In an acute heart attack, the myocytes break down. Suddenly the contrast agent can go everywhere. It's got 100% distribution volume, so you're much brighter than an infarct. And in chronic or in focal fibrosis, there's also the collagen, gets bigger, and that's why they also accumulate in fibrotic scar. And then the typical image in a heart attack looks like this. We make the picture look bright in the scar, and we define that, normal is black, but that's just a definition. It's a really good technique, but it actually is a little bit harder than sometimes we think. So I'll talk a little bit about the pitfalls. The first is the resolution. So we acquire a voxel that's typically about 1.5 by 1.5 by 10 millimeter. So that's an awful lot of myocytes, an awful lot of fibroblasts, an awful lot of blood vessels. So you always have to remember that, this is not actually, sometimes you think, oh, there's one little spot of fibrosis, where you're looking at a whole cylinder, a whole cube of a lot of stuff contributing. So there's a lot of tissue components there, and you're looking at the combined effect of all of those. The second thing is that it can be quite easy to find the focal fibrosis, but not always. And it can be quite difficult as well, because if you have sort of a subtle bit of fibrosis somewhere, then visually looking at this, it's quite easy to miss it. So we would say, and it's not projecting quite as well as it does on my screen, but I would say at first glance, this picture on the left, it looks pretty normal. That one here, I think, has a bit of subtle enhancement in the lateral wall. Is that visible? And this one's got a nice spot of mid-wall enhancement. But let's go back to that first picture, which we all thought was normal. If I window that a little bit more aggressively, beginning to see something in the lateral wall. If I window it even more aggressively, another thing that probably is a bit of mid-wall enhancement in the lateral wall. So that shows where experience unfortunately comes in. It's a visual technique. It's not objective. And with the fellows, when they start out, there's a lot of over-reporting. There's a lot of under-reporting with these subtle findings, because unfortunately pictures aren't always perfect. You don't always have perfect suppression of normal myocardium. There's often a little bit of noise in it, or, the technique hasn't the patient's taking a breath. So one of our most common conversations is around, is this true late guard, or is it an artifact? Tier 1 and 2 T2 mapping are more objective because they give you a number, but they're also not without their problems. And the specific problems here are that the T1 values that you get are strongly dependent on how you acquire the images. So there are lots of different techniques around. They also depend on field strength. And the same goes true for T2. So the number that Jason or others have in their department isn't the same number that I get. So we have to have normal ranges specific for a particular standard and particular setup. So it's difficult to make that work in a multi-center environment. And as part of CARDIO-IMID, as Maya introduced, we are hoping to do a prospective registry where we want to in particular pick up patients who go for cardiac MRI scans for suspected heart involvement. And one of the biggest conversations we're having around T1 mapping, how do we standardize that across 30 sites, which all do it slightly differently. So that's a fairly significant challenge. One way around that potentially is what we call the extracellular volume mapping. Here we take a T1 map before we give contrast, and then we take a T1 map after we've given contrast. And now, in order to keep it you have to think a little bit about what might happen. So what does the contrast agent do to the T1? It reduces it. And where does it distribute the contrast agent? In the intracellular or the extracellular space? Just the extracellular space. So if you have more extracellular space, there should be more contrast there. So you should have a lower T1 in people or in myocardium that has more extracellular volume. And then using this formula, you can then figure out what the actual percentage is of extracellular tissue within your voxel that you're imaging. And that's called extracellular volume mapping. And that takes away, because there's an equation that has T1 before and after in it, if you have a different method that measures the T1, because there's a ratio, you take out that difference between the methods. So it's a bit more similar between 1.5T, 3T, and between different machines and methods. So ECV has its advantages, but because you've done a lot of calculations, it's probably a little bit less sensitive than native T1 mapping on its own. Right, so with that background, let's talk about where we use cardiac MRI in patients with IMIDs. As I mentioned, it's the big things, so the myocarditis, the heart failure, and the pericardial disease. Most of you will have seen the ESC guidelines on myopericarditis, which now group myocarditis and pericarditis into myopericardial syndrome. And cardiac MRI, excitingly, is now considered the diagnostic test in these circumstances. So certainly for patients at low and intermediate risk, the recommendation is to use cardiac MRI to diagnose myopericarditis definitively, in addition to all the clinical workup, etc. And that includes those patients with autoimmune disease. So let's show you a quick case that Chin kindly gave me from one of his patients. So here's a patient with recent diagnosis of systemic sclerosis. I have that little spot of late GAD in the lateral wall, which I think in this case is pretty unequivocal. We do a T1 and a T2 map, and relative to our normal ranges, the T1 was raised at 1349, this is at 3 Tesla, and the T2 was sort of normalish, upper limit of normal, I think it's 42, Chin. So it's just on the edge. But the patient was treated, and when we rescanned them, it seemed like the late GAD had become bigger. So this is a replacement fibrosis in a chronic inflammatory process. The T1 had gone up rather than down, and the T2 had gone up a little bit as well. So what I'm trying to illustrate here is that you do need to have, you need to look at more than one thing when you look at immune-mediated inflammatory disease in order to be reasonably certain that you have an acute process in the heart rather than just looking at long-standing processes. This is a case from the literature just to show the how we use it in pericarditis. So we see the effusion. You now see the white ring around the heart, nicely highlighting inflammation in the visceral and the parietal pericardium. So this is acute pericarditis. So in IMIDs, there have been quite a fethem papers that show that cardiac MRI picks up a lot of abnormalities in this patients. This is one of the bigger studies, 200 patients, 26% of them had focal fibrosis, 2.5% had edema, but that's just using the T2 weighted imaging. So that's just visually looking at it. And that means if the whole myocardium is inflamed, you don't see it because you don't see any relative differences. So that's almost certainly underreporting. Subsequent studies have looked at that in a little bit more detail. And here again, they've reported that while in these patients, the focal edema and the visual T2 weighted imaging was only 12%. When you do T2 mapping, it goes up to 61%. So a significantly higher pickup rate with T2 mapping and also T1 mapping relative to the late GAD. No, that's not true. So late GAD and T1 mapping were quite similar. Others have also reported an increase in native T1, specifically in systemic sclerosis. It's been shown in rheumatoid arthritis, where you have increased in T1 and ECV. And this isn't just all-comer patients. This is not patients with acute inflammatory episodes. And I think that's important to remember because there's the background inflammation that clearly affects the heart. And we'll come back to that in a second when I come back to the ESC guidelines and how they may apply to patients with IMIDs or maybe not apply to patients with IMIDs that well. And this is from a poster that we had at the ESC this year, which is a little bit complex, but I just want to walk you through this. So here we looked at patients, healthy volunteers, which is always the first column. And then we looked at patients with fairly early systemic sclerosis, and then patients that had systemic sclerosis for a long time. And we looked at patients who were positive for CCP, so patients at risk of developing rheumatoid arthritis, but who haven't got it yet, and patients who've had rheumatoid arthritis for some time. What I think is interesting to see is that the T1 is up for all of those groups already. So it seems to be quite an early biomarker of inflammation in the heart, with a lot of overlap, of course, with healthy volunteers. It's not a great biomarker for individual patients, but for group differences, there seems to be clearly a trend. ECV, the second chart, not so much, apart from sort of late disease, but again with a significant overlap. And I think I mentioned that ECV is considered to be a little bit less sensitive because of all the calculations and that go on in order to derive it. Perfusion reserve, we haven't talked about that much, which is something we do with quantitative perfusion, also is impaired, certainly in patients with late systemic sclerosis and late rheumatoid arthritis. And then we also do something called phosphorus spectroscopy, which is an MRI method that looks at the energy handling in the heart. And we find that, interestingly, even patients with early rheumatoid arthritis seem to have abnormalities in their energy handling. We don't know quite yet whether that can be more widely considered a biomarker, because we only have so in the order of 15 or 20 patients. And then, so the last slide on this topic, this is from a paper that's just come out, which I found yesterday when I prepared for this talk. Different IMIDs have different cardiovascular manifestation. We know that systemic sclerosis seems to be the one that's most associated with diffuse fibrosis, whereas the other processes have sort of a varying degree of diffuse fibrosis measured using T1 mapping. So just quickly coming back in the last couple of minutes to the ESC guidelines for myopericarditis, as I said, a very big role for cardiac MRI. But are these guidelines, are the criteria actually applicable to the particular situation of immune-mediated inflammatory disease? And there are a few points to consider. The first is that the presentation of myocardial involvement in IMIDs is completely different to viral myocarditis. Viral myocarditis follows this course often that's been outlined in the ESC, acute or subacute, chronic, recurrent, remission. Whereas patients with IMIDs, of course, have sort of a backlog inflammation in the heart as part of their systemic illness. So whether these guidelines per se are applicable to our patients, one may consider, and it much more commonly leads to residuals in our patients. In this context, work that I've published in Myers a couple of years ago, I think is quite interesting. Is, do things change once you have cardiac manifestations with IMIDs? We did this in patients with systemic sclerosis, and we actually found as long as they didn't have particular excessive disease flares, that the findings in the heart are pretty stable. The second sort of point of the guidelines is the presentations, and that doesn't really work for IMIDs at all. So a few patients do present with acute myocarditis, but many present subacute, chronic. So again, the guidelines are not that helpful. And then finally, the actual MRI findings in patients with IMIDs are quite different. And I've shown you quite a lot of examples already how patients who just have stable disease have abnormal T1, they have abnormal T2, just because of the fact they have a chronic systemic inflammatory condition. And the guidelines refer to the so-called Lake-Louise criteria, which use one criterion of a T1 weighted or mapped abnormality and a T2 based criterion. And in order to have myocarditis according to the Lake-Louise criteria, which are the criteria that inform the ESC guidelines, you have to have one of each. But as I showed you earlier, just because of the fact you have an IMID means that very often you have a bit of myocardial edema, makes that not a great additional biomarker to say you have acute myocarditis. Very often you have a little bit of late GAD or raised T1. You often have pericarditis, and you sometimes have AV systolic dysfunction. So I think these guidelines are great, but they're not particularly useful for IMIDs. And a paper from King's again this year began to look at that a little bit. So they applied the Lake-Louise criteria to patients with IMIDs, and they found that they were not particularly sensitive or specific when applied to this particular population. The last point to mention is the treatment effects. And I think that really is the area where we know very little, but where using cardiac MR, using PET, and Jason really nicely talked about this, this is where we need to go. So we need to understand if patients have biomarkers, imaging biomarkers of cardiovascular involvement, and we treat them with whatever it is. Is that good for the heart? Is that bad for the heart? There is nothing out there. There's no data, so we don't know. And we have all these case discussions today, and we talk about we're giving them this drug and that drug, but we don't really know what it does to the heart. And the heart is an organ that, as Maya showed in the introduction, is extremely important and perhaps under considered a lot of the times. But we need studies that tell us that X treatment, Y treatment, what it does to the cardiovascular manifestations. And this is pretty much, I think, the evidence that we have. So like 35 patient studies using a range of treatments, suggesting that perhaps, there's a slight improvement with them. And there was an even smaller study of antifibrotic therapy in 10 patients, which also suggested that maybe, cardiac fibrosis might go down. But the evidence is very, very slim. Maya and I have done a study called CARDIO some years ago, which was in rheumatoid arthritis treatment-naive patients. Our primary endpoint there was aortic distensibility, which is the aorta going bigger and smaller in the cardiac cycle. And we showed that giving anti-TNF can improve aortic distensibility a little bit. But again, a small-scale, single-center study. And therefore, to summarize, I think Plein clearly shows a lot of abnormalities in patients with IMIDs, not the same in different IMIDs. There are clearly distinctions between the different diseases. It may be able to track cardiovascular involvement, and therefore I think that really is the area that we need to focus on in the years to come. There may be some ability to predict cardiovascular risk. I think we need more specific guidelines for autoimmune disease and cardiovascular involvement rather than DAC guidelines, because the use of conventional criteria doesn't really work in this patient cohort. And lastly, I don't think you expected that when you came, so hopefully you remember what T1 and T2 is next time you read it in the papers. And with that, thank you for your attention.
That was a brilliant, Sven. I never think that the MR physics for dummies, rheumatologists, can get any better, but it was superb, and I think a perfect take-home element of the day. Are there any questions immediately? Otherwise, we can kick off. Oh, yes, Pedro.
I'm used to looking at MRIs of the spine and sacroiliac joints, right? And there's also noise there and hyperintensities that do not necessarily reflect inflammation. And there we look at things like the exact anatomical localization of the lesion. We look at it from a contextual perspective. Are there structural lesions? How do you decide with such a small area, and how do you decide if it's noise or signal with the heart?
Yeah, it's a really good question. And the problem with the heart is that it moves all the time. The spine doesn't so much, and there are relatively small structures and small abnormalities. So yes, there isn't a magic answer to that. It's having really strict protocols that make sure that quality is assured. We often repeat the imaging in different phase encoding directions. So if you like, take the picture in with two different cameras, if you like, just to be sure. So if we see it in one phase encoding direction, not in the other, we say it's an artifact. We're meticulous about the quality. The quality has to be good. And then it's sort of training, and that's why training in cardiac MR unfortunately isn't very quick. You do need to see a few hundred cases before you're reasonably confident what's an artifact and what isn't. And then every type of MR image, so whether it's a late GAD image or a perfusion image, they all have different artifacts. So you want to learn about all of those and recognize them. And they're a little bit specific to your scanner, so you begin to understand what's an artifact on your Philips versus your Siemens. So I'm waffling a bit because there's not a single answer. There's not a straightforward, this is how you do it. But it's a combination, as always, of trying to have the best possible image quality you can get with the best possible training of those reporting. And that concerns me just a little bit about the ESC guidelines, because it's not easy. And this is now what people around Europe are supposed to do. I mean, they're supposed to do it in Grimsby and in Copenhagen and in everywhere. And I think the level of training is not sufficient in many places to do this well. So there will be a lot of over-reporting, particularly of late gout, I think, and there will be a lot of under-reporting from inexperienced centers. So we really need to combine this with redoubled efforts for training.
And I think that just emphasizes the point that the risk is then, because we're used to then treating to a target and a measure, and when there are such uncertainties, we're not yet there to be able to say, and there's a big, significant narrative that's emerging to go for these targets or measures, and the evidence base just isn't there.
There's a question online: can cardiac detect subtle heart inflammation early enough before permanent damage occurs? It's a superb question, and we're lacking the data to know that. Intuitively, you would think that having abnormalities in, the fibrosis in the heart and inflammation in the heart can't be a good thing. But we don't have the longitudinal studies to know how these abnormalities translate into poor outcome. I mean, we're just looking at that. So with my inner time in Leeds, we have acquired some cohorts of patients that with both systemic sclerosis and rheumatoid arthritis. And we now have some 10, 12-year follow-up data on those. So we're beginning to look at the long-term effect of these abnormalities. And Dan Knight, a slide that I skipped over in the interest of time, has done some interesting work with cluster analysis, looking at different clusters of imaging phenotypes and how they may relate to long-term outcome. I think this network is a really good opportunity to look at those things as a collective, because many of us have 100, 200 patients, and that's often not enough to have those, outcome studies. But if we pool our data, I think as a community in the UK, we should be in a really good position to define some of those really, really important questions. Dr. Patel, would you like to ask a question?
It's Dr. Pal from Manchester. Yeah, I was just wondering the difficulties of interpretation. In some areas of practice, for example, in spondyloarthritis, breast images, AI has been used with some benefit so far, I understand. Is there any application in this very specialized field of yours?
Yeah, coming. The heart is usually the last organ where these things are applied because of, as I mentioned, it is the most difficult to image. But I have no doubt if we speak in 5 years that some of these things obviously have been taken over by AI. And some of the analyses that we do are quite easily learnable by a machine. Others need a bit of experience. But I have no doubt that, as in every other area of radiology, it will be AI-supported interpretation of these things very soon. There's another question from John Davies. Is troponin a more sensitive measure of myocardial injury? Yeah, another interesting question. As you know, we often see a little bit of troponitis in many IMIDs. And is it more sensitive? It probably, conceptually, I would think it should be significantly more sensitive, because it's... And that's why I made the point about even the late gadolinium enhancement. I told you the voxel size and the number of things that go on in a single voxel that we then see as a tiny 1 millimeter. You can hardly distinguish the voxel on the MRI picture. But within that, a lot goes on. And if you had like 1 in a million myocytes being unwell in your voxel, it would change the signal by 1 millionth, right? Whereas troponin, there'll be a slight troponin leak, and with this highly sensitive troponin assays we have now, you should pick up, maybe not 1 in a million myocytes, but, 2 or 3 or 4 or 5 in a million. So yes, I think troponin, without being too scientifically answer the question, I think should be always more sensitive. But, what does it mean as the second question?
Yeah, and I think
specific to some injury. I think once you have, the replacement fibrosis and you have the high T2, the unequivocal evidence of edema, that's got to be a more specific and clinically significant abnormality than having a slightly raised troponin.
Yeah, and obviously troponin, just for the juniors as well. Remember, troponin can go up in a number of with a number of etiologies, renal pathology, infection, etc. The type of troponin matters. we think, troponin TNS. I'm going to introduce the co-moderator later, who's expert in that with skeletal muscle involvement. And Christiana, one of our fellows, she's also looked at this recently through all the literature, and it's not that clear-cut, bizarrely. As Sven says, interestingly, we'd assume that troponin will go up when there is clear abnormality and suggestion on imaging myocardial injury. It's not clear-cut, and that might go back to Sven's point as to whether the CMR measures how clinically pertinent they are. So we use troponin, but I think a bit of caution sometimes in interpretation.
Yeah, well, in myositis, in particular, troponin I is much more reliable and valuable than troponin C.
Yeah,
I've been called a couple of times, well, if not more, about raised troponin Cs that were from muscle rather than the heart.
Yeah. Okay, so nicely introduces onto the, I can introduce our co-moderator for this next session. We'll have Sven and Professor Pedro Machado. He's a professor of rheumatology and neuromuscular disease at UCL and an honorary consultant at UCLH and Norfolk Park to kick off the cases this afternoon. Thank you.